Welcome back to Corduroy, the heart of clinical care. I'm your host, Dr. Roy Ziegelstein. Today, we've got a great episode lined up, including a conversation with Dr. Stephen Lin. Steve is the Chief of General Primary Care at Stanford University School of Medicine, as well as the founding director of the Stanford Healthcare AI Applied Research Team. And of course, as you may have guessed, Steve and I will discuss a topic on every clinician's mind: the impact of AI on our roles and on patient trust. We also have a number of segments where we'll dive deeper into interesting research, discuss technological advancements, and I'll elaborate on a few of my own personal examples from clinical practice. It's a packed agenda, so let's get started. For my first segment, I'd like to reintroduce what we're calling Recapping the Research, where we'll discuss the latest peer-reviewed studies or major reports from reputable associations and the clinical implications. And I wanted to start off with findings from a survey conducted by the American Medical Association, which is called, of course, the AMA. That survey found that physicians' use of AI has more than doubled since 2023. More than doubled in just about 3 years. And this echoes recent findings from a new survey conducted by one of my employers, EBSCO Clinical Decisions, that found that 89% of clinicians believe that AI for clinical decision support will lead to better outcomes and higher quality care. Now, it's a rosy picture in that regard, to be sure. And also you have to think about, what are clinicians using AI for? They're not just using it more, they're using it for more things, from documenting their care, to first draft responses to patients' questions, to chart summarization, to summarizing medical research and supporting clinical decisions. On the one hand, as these data imply, physicians are excited. They feel that AI helps them care for patients by being more efficient and more effective. On the other hand, though, physicians expressed concern that over-reliance on AI might erode young physicians' skills, and there's also concern about trust and even the potential for harm. So I was thinking about this, and believe it or not, I'm going to compare it to another tool. That tool is the electric circular saw. And I looked this up. It turns out that the portable electric circular saw was invented in the 1920s. Imagine for a moment how a person who always sawed by hand would feel if they were gifted a portable electrical or electric circular saw at that time. They'd be excited, just like physicians are excited about AI. But they would also recognize the immediate impact on how fast and how well they could do their job, just like physicians realize that about AI. And at the same time, they probably would be worried about accidents and harm, and also about whether young carpenters might lose their woodworking skills. I think that's actually where we're at right now. It's a combination of excitement and also some skepticism and concern. And I think this is really where trust and trustworthiness come in. And I think we're going to hear a lot more about that, not only in the podcasts on Corduroy, but also in the future in healthcare. Next, I wanted to comment on the updated guidance on the management of blood cholesterol from the American Heart Association and American College of Cardiology. It's all over the press, and for understandable reasons, because heart disease is something that really everybody cares about. I'm going to boil down the guidance into 3 things to take away. The first, treat earlier. Full stop. Treat earlier. That's really key, because if we treat earlier, we can have a huge impact on cardiovascular disease and mortality from cardiovascular disease. Second, consider treating more people. That's also important for the same reasons. And third, use other things besides just the risk calculators that many people are familiar with to refine risk assessment and personalize recommendations. Again, 3 things: treat earlier, consider treating more people, and use other things besides risk calculators to refine risk assessment and personalize recommendations. Anything I missed? Let me know on LinkedIn at Roy Ziegelstein. That's Ziegelstein, and you might see it featured in next month's episode. On to another segment, this one dubbed Tech Talk, where we'll discuss innovations in technology, particularly AI, since that's the theme of our episode and is, of course, permeating many aspects of our daily lives. In a report by ECRI, misdiagnosis due to AI was expressed as a top concern for medical professionals. Now, ECRI is an independent nonprofit organization that's focused on healthcare safety. That's really key. We need organizations like ECRI, and so when they say that misdiagnoses due to AI is a top concern, we should listen. So what do I think of this? Well, I would say that many clinical decision support tools give warnings that the information that's provided is meant as education or support of clinical decisions rather than on actually making decisions for physicians. The truth is, though, I think of this a lot like other warnings. You know, we're all used to getting a piece of equipment or something like that for use around the house with a warning label. And the truth is that for years, concern has been expressed about consumers' tendencies to ignore those warning labels. I think this is just another example. I think that we have to be prepared for a world, as ECRI seems to be, in which clinicians are perhaps ignoring those warning labels. And that's a shame because they really do need to be adhered to. Clinical decision support is meant to support clinical decisions, not to provide diagnoses. But I think it underscores something that I have underscored and highlighted and emphasized here on this podcast, which is trust and trustworthiness in the clinical decision support tool is paramount. That's how we will avoid misdiagnoses. I could go on, but there's plenty more on AI and clinical practice in my conversation with Steve in a bit. Now I'd like to introduce a new segment called Personal Perspective, where I'll share an example from my clinical practice, blinded, of course, to protect patient privacy, that will help illustrate some of the things you may be facing in your own day-to-day practice. In the last episode, you may remember, I talked about an example from the pit where Dr. Santos didn't check the outputs of AI closely enough, and she suffered for it, and ultimately, likely, so did the patients. Today, I'd like to share my thoughts on the human-in-the-loop part of AI that we're navigating in daily practice and give you a real example of how I implement it in my daily practice. In my own daily practice, I use AI fairly regularly for clinical decision support. It provides me information that either is in an area that I may not be completely confident of, maybe I feel like I'm not up to date in, or a field that, frankly, I feel confident in, but I might be 99% confident. And for my patients, and I hope for yours, 99% is just not good enough. Let me give you a specific example. The other day, I was taking care of a patient who is on a drug that, really hasn't been used in many years, at least not in widespread use. So my own familiarity with it was okay because I had used it earlier in my practice. I'm talking about 20 years ago, but maybe not as top of mind as it should have been. And then I was wondering whether it had an interaction with another drug that this patient was taking. And so I don't think I could have been expected to have known that. And again, the potential for harm from making a mistake is very high. And so I went into my drug interaction checker and looked about the potential drug interactions, and it gave me very practical advice that was very helpful for my practice. I hope that example was helpful and might spark some ideas for you to try in your own practice. And now, my interview with Dr. Stephen Lin. It's a real pleasure to host Steve Lin in this podcast. Steve is a practicing family physician. He's clinical professor of medicine and chief of general primary care at Stanford. He's the founder and executive director of the Stanford Healthcare AI Applied Research Team, and really an internationally recognized expert in artificial intelligence in healthcare and on the use of AI to transform what clinicians are able to deliver to their patients. Steve, welcome to the podcast. Today, we're going to focus on three things. The first is the role of physicians before AI. The second is the role of physicians with AI. And the third is AI and trust. So briefly, could you just tell the listeners, how did someone like you get involved in AI from the beginning?
Sure. Well, first of all, thank you, Roy, for inviting me to join you. I'm honored and really excited for this conversation. The story of how I got to do this. So first of all, I have no technical background in computer science or AI. I am, as you said, a practicing family physician, and I've been in clinical operations leadership for some time. I really got into this whole space about 7 or 8 years ago when I saw the burnout that our primary care clinicians were struggling with in clinic. Many of our faculty members left practice altogether, left medicine altogether, because of all of the increasing demands put on physicians. We can't see our patients the way we want to. We don't have time. Documentation burden was an incredible barrier. The overload of information and fragmentation of information in the EHR was a dissatisfier. And I really struggled to see all of my friends and colleagues leave. And so it was with that lens that I started to learn about new technologies, automation opportunities, this new thing called AI that was just starting to enter into the national conversation at that time. And that's the angle in which I'm approaching all of this, is how do we use this technology to bring back the joy of practice?
Yeah, that's great, Stephen. And I have to say, kind of a similar story to my own. And you really addressed the first point at all already, really, which is the role of physicians before AI. You actually answered the question so nicely by introducing yourself. So I'm going to go right away to the second topic, which is the role of physicians with AI. You know, let me start by saying it's hard enough having people accept that AI alone may outperform clinicians in making patient care decisions. It's even more difficult to explain how AI alone might be better than a human plus AI. How do you explain that to people?
Yeah. Well, what you're referring to is a lot of very thought-provoking studies that have been done recently, comparing diagnostic ability of humans versus humans plus AI versus AI alone. I think your listeners need to understand that these are essentially test questions, right? They're experimental, non-real world case studies of things that, often appear in our physician boards, for example. And they test this and amongst these three groups and then see which group has the highest chance of getting the closest answer to the right answer, the source of truth. And in this case, AI alone wins compared to physicians and physicians plus AI. And a lot of people in the medical community were shocked by this. And it really has led to a lot of soul searching amongst a lot of physicians around this. I will just say, again, that this is textbook. This is, textbook diagnosis of medical conditions. And in the real world, that's not all that physicians do. If we were just machines that ingested data and put out an answer, yeah, I mean, we would quickly be replaced by AI. But the reason I'm so optimistic that physicians will not be replaced by AI and that the role of the physician plus AI is really a partnership that enhances and augments the capability of the human physician is because real-world medicine is not a diagnostic game. It's around taking all the data that you know exists, marrying that with what you know about the patient that doesn't exist anywhere. Their life situations, their preferences, their values, their beliefs, along with the realities of administrative part of practicing medicine. What does their insurance allow? Where do they live? What is the formulary? All of these things, you're combining all of this together. Our human brain ingests all of this information and then comes out with sometimes, perhaps not the textbook answer, which is what the AI provides, but the best one in real life for that patient. And that's the role of the human physician today, is to make the best human decision for the patient outside of just an experimental textbook environment.
That's great, Steve. You know, I have to say, I love having this conversation with you, but I'm also so glad that it's being recorded as part of a podcast, because what you just said was really beautiful and perfect from my perspective. To go a little bit younger than physicians, students, maybe younger physicians, young residents, how do you think AI will impact the training of these people, and how will it impact, in particular, their clinical reasoning skills from your perspective?
Yeah, I think there is a real sense of urgency amongst the medical education community. You are an educator yourself. I am an educator myself. In thinking about the potential impacts of AI in education, I think top of mind is there going to be over-reliance on AI amongst our learners in a way that they lose some of the fundamental clinical judgment that can only be developed over time in practice in the real world setting? And I think that's a reasonable question, and I think it's a question that we're all struggling with. And I do think that if we don't put reasonable guardrails around the use of AI for our learners, I can envision a future where our next generation of clinicians really lack some fundamental human judgment. And I think the best way is for us to mirror, as educators, the most appropriate use of AI, and that is we always put human judgment and clinical intuition first. Then we can always check in with the AI to see, is there anything we're missing? You know, is there anything that's a blind spot? Because we are only human, we have blind spots. And for the AI to augment that human clinical judgment, but not the other way around. And if we can model that behavior, if we can show that, you know what, we're not denying the power of AI. We're not saying you can't use AI, but we're showing you the right way to use it. Human first, AI second. There's a certain humility to that modeling, right? It's like we're all human. We can all be better. This AI allows me to be a superhuman. And this is what I use AI for, to augment my clinical reasoning, but not to replace it. Let's model that first. And then let's, as educators and institutions of education, put in reasonable policies for responsible use of AI. I think that's going to be the way that we ensure we have a safe future.
Yeah, again, Steve, I have to say I'm so glad this is being recorded, because that was, again, just really perfect from my perspective. I think, you know, it's impossible to be somebody that comes from Hopkins without quoting Osler. So I'll just say that, you know, Osler didn't know about AI, but he knew about books. And he really pointed out that books could not replace the patient in terms of the way that students and residents would be taught. And I actually, to be honest, I think it's disappointing to me that many medical education colleagues view AI as something that will interfere with the process of clinical reasoning and with teaching clinical diagnostic skills. I think it's the opposite, and I think you have a similar perspective. If it's okay, I want to shift now to AI and trust, which is sort of the biggest issue right now for clinicians using AI. So clinicians want information on which AI clinical decision support systems they can trust. How do you think that we can judge the trustworthiness of AI clinical decision support systems, and who should do that? Like, who should be responsible for that?
Yeah, that's such a great question, and that could be an entire podcast episode in and of itself. But here's the Cliff Notes version. I think there's responsibility at the individual user level, the physician, but then there's also a societal responsibility to put in the safeguards, the evaluation, the approvals processes in a similar way that we have for medications and devices regulated by FDA, for example, that ensures that there's a basic level of safety and trust in these systems. And I think that the model developers need to be held accountable for when things go wrong. It cannot be the physician's responsibility, the entire medical legal responsibility for using AI or not using AI entirely on the two shoulders of the physician. That cannot be the case. I think if that's the case, then we as a society have failed physicians. But at the physician level, we also need to educate our current workforce as well as our future workforce on how to critically evaluate AI. Because AI today doesn't come with a, ingredients label, right? Or, black boxes and things like that. And so we need to have a basic foundational AI literacy across the entire healthcare workforce. And there are multiple professional organizations, multiple institutions that are working on this. We still don't exactly know what should be the gold standard curriculum. What are the competencies across the spectrum of learners from, undergraduate medical education to graduate to practicing physicians? But we're developing those. And I think what you'll see in the next 5 years is the development and implementation of the curriculum, the basic foundational curriculum that everybody should know. But it's really tricky because this technology is advancing at a pace that is never before seen. And so anytime you try to develop a curriculum, 6 months later, it's completely outdated, right? So the challenge for us as educators is to figure out what is truly foundational, what can be evergreen, and how do we deliver that into an already crowded training environment where medical students, residents, fellows already have way too much to learn. But I do think that this should be prioritized. It's as important as evidence-based medicine. When we teach our learners how to critically evaluate literature, this is as important as that. We need to teach our learners how to critically evaluate AI.
Yeah, and once again, I find myself agreeing with everything. The only thing I would say is that it won't be 5 years that we have a curriculum. It might be 5 months. I mean, the speed, as you said, the speed of everything. So my question here is more like a personal one. So right now, there isn't, as you said, there really isn't like a consumer reports that tells us, about the trustworthiness of AI clinical decision support. And yet you as a physician and I as a physician actually use AI in clinical decision support and in terms of, taking care of patients. So on a personal level, what is your experience with using AI clinical decision support? There's no need to name specific tools, but just in general, and how do you know if you can trust the AI clinical decision support system that you're using, and also what level of error are you willing to accept as a doctor?
Yeah. Well, the level of error that you can tolerate depends on the use case, I feel like. Something that is a clinical decision support for prevention, for example, might be very, very different. That level of tolerance, risk tolerance, might be very different than something that's a clinical decision support to one in the ICU, for example. So the use case in the environment will dictate what level of error you can tolerate. Some folks say we want 0 error, and that should be the benchmark for AI. I don't think that's possible. I don't think that's reasonable. And we also do have to say, what are we comparing AI to? If we're comparing AI to perfection, the AI will never meet that standard. But if we're comparing AI to current state, the quality of care current state, well, I'm sorry to say to the fellow human beings that we're not doing so well in many places. And so AI, despite some limitations and errors, might, if it's better than current state of medical delivery and it's safe, then I'm all for that. So setting the standard appropriately, figuring out where the risk tolerance is depending on setting is going to be a case-by-case basis. With the first part of your question, like, it would be really great if we, for those who are not AI literate, to be able to trust, a trustworthy source, for that. And, this is a concept that's been proposed by many institutions, by many bodies. The National Academy of Medicine, for example, put out a report a couple years ago, which I was very fortunate to be a part of, that said, well, what about some sort of, certification process, like LEEDs, for example, for environmentally friendly buildings, right? Something like that as a sort of a parallel, as a conceptual framework. But you have some sort of certification process where we say this model has been evaluated, is deemed safe and responsible, and as free of inequities as possible, things like that. But so far, there hasn't been necessarily a consolidated, unified national effort towards a system like that. And so individual institutions are left to figuring out how are they evaluating AI on their own. And so it's messy, but I'm hopeful that, again, in the coming years, months to years, that we'll have some semblance of some sort of process that we can all sort of start to rally around. But for the time being, I think it's important for each individual physician to get a basic sense of AI literacy so that they can do some of this evaluation on their own.
Yeah, Steve, I want to thank you. I mean, you shared some amazing insights with our listeners and with me personally, and I really want to thank you a lot as we talked about the role of physicians before AI, the role of physicians with AI, and importantly, AI and trust. Steve, thank you so much for being a guest on the podcast.
Thanks for having me, Roy.
What a great conversation that was. I hope that everybody enjoyed it as much as I did. I want to thank you again for joining me today and for listening to the podcast, and a special thanks to my guest, Steve. Please stay tuned for more episodes, which will be released the first Tuesday of every month. Like and subscribe to be notified of new episodes, and please connect with me on LinkedIn. I'd love to hear your feedback. Until next time, stay true to the core.